welcome back to my channel. And as mentioned earlier, I have started a series of rcog green top guidelines, and today the topic of our guideline is intrahepatic cholestasis of pregnancy, and it is a green top guideline or GTG number 43, which was updated on June 2022. And previously we have seen that what are the level of evidences means, and what are the grade of recommendation means, and what is the meaning of the good practice point. If you want to know all about this, please say in the playlist, you are going to find that video. So let's start with our first guideline, and this is started with key recommendations, and these key recommendations here are very important for the exam point of view as well as in day-to-day practice. So what are these recommendations? And that the number one is the diagnosis of the intrahepatic cholestasis of the pregnancy, which is also known as ICP. They should be considered in the pregnant women who have itching in a skin of the normal appearance and a raised peak random total bile acid concentration of 19 micromole per liter or more. Here you see that it is written that this is a grade D recommendation. So next point, that the additional laboratory or the imaging investigations are not recommended unless age is associated with the atypical clinical symptoms, the presence of the relevant comorbidities, or in the early onset severe ICP. Consider additional postnatal investigations in a woman in whom the resolution of the abnormal liver function test is delayed or does not occur. Number 3 is consider the discussing the care of the woman with the severe, very early or atypical presentations of what appears to be the ICP with the hepatologist. It is grade D recommendations. The next is to confirm the diagnosis of the ICP in the postnatal period at least 4 weeks after the birth, and with the resolution of the itching and the liver function test returning to the normal, including the bile acids. Next, advise the woman with the isolated ICP and a singleton pregnancy that the risk of the stillbirth only increases above the population rate once their serum bile acid concentration is 100 micromole per liter or more. In women with the peak bile acid 19 to 39 micromole per liter, it is the mild ICP, and no other risk factors, advise them that the risk of the stillbirth is similar to the background risk. Consider options of the planned birth by the 40 weeks gestation or the ongoing antenatal care according to the national guidance. In women with the peak bile acid 40 to 99 micromole per liter, moderate ICP, and no other risk factors, advise them the non-risk of the stillbirth is similar to the background risk until 38 to 39 weeks gestation. Consider planned birth at the 39 to 39 weeks gestation. In women with a peak bile acid 100 micromole per liter or more, severe ICP, advise them that the risk of the stillbirth is higher than the background risk. Consider planned birth as 35 to 36 weeks gestation. Advise women with the ICP and a twin pregnancy that the risk of the stillbirth is higher compared with the twin pregnancy without ICP. Clinicians, they should be aware that the fetal ultrasonography and the cardiotocography CTG do not predict or prevent the stillbirth in the ICP. So what is the purpose and the scope of the guidelines? You don't need to do it at the start, but if you have time, you can read them at once. So starting with the introductions of the intrahepatic cholestasis of the pregnancy, that the care of the woman and the pregnant people with the ICP is driven by the concern from the women and from the healthcare professionals over the potential increased risk of the stillbirth. Reduction of the stillbirth is a priority in the maternal care in the UK. Prevalence is influenced by the genetic and the environmental aspects and varies between the population. In the UK, ICP affects 0.7% of the pregnancies in the multi-ethnic population and 1.2% to 1.5% of the women of the Indian, Asian, or the Pakistani Asian origin. So the incidences are very important. You have to highlight whenever you are going to do the guidelines, always highlight the incidences because they are very important. So moving next, intrahepatic cholestasis of pregnancy is a multifactorial condition. It is characterized by the pruritus in the absence of a primary skin condition with abnormal maternal bile acid concentration. The onset of the symptoms is most common in the third trimester, but can be earlier in the pregnancy. Alternative diagnosis such as a preeclampsia, they should always be considered before a diagnosis of the ICP is made. It is also possible for the other conditions to coexist. Pruritus and raised bile acid concentrations, they should return to the normal after the birth. Ideally, all women with the ICP, they should have the liver function test, including the bile acids, checked after the birth, and a proportion may have persistent abnormalities suggestive of the additional or alternative comorbidities such as the non-alcoholic fatty liver. Few studies they have reported the comprehensive postnatal follow-up of the woman to assess for the additional diagnosis. There are no clinical features or the laboratory pattern that are unique to the ICP. As other conditions, they can cause the itching or raised bile acid concentration in the pregnancy. Around 25% of the pregnant women they develop itching. The majority of these they do not have or do not develop the ICP. Historically, ICP has been diagnosed in the women on the basis of the self-reported itching together with the elevation of any of the wide range of the liver function test beyond the pregnancy specific limits. There is now increasing evidence that in the singleton pregnancies, most liver function tests they do not reflect the risk of the fetal demise, and that the only maternal total bile acid concentrations results as associated with a high risk of the stillbirth. So this is important that it is nowadays it is the total bile acid concentration results as associated with the risk of the stillbirth. A meta-analysis of the 23 studies that involves 5,557 women with the ICP and 165,136 healthy controls, and the first individual patient data analysis of the 5269 women with the ICP from the 27 studies have been published since the guidelines was last updated. In singleton pregnancies, the stillbirth was associated with the maximum total bile acid concentrations, especially over the 100 micromole per liter. In the pregnancies with the comorbidities that themselves may impact on the pregnancy's outcome, such as the multifetal diabetic pre-eclamptic pregnancies. These must be taken into account when considering the risk and the care options. Bile acid concentrations are not associated with the intensity of the itching. Other liver blood tests such as the alanine transaminases or the aspartate transaminases are not associated with the pregnancy outcome. In light of this, the consensus is now that the diagnosis of the ICP requires the elevated maternal bile acid concentrations, and that the women and the pregnant people with the itching are isolated raised transaminases along with the normal bile acid concentrations. They should not be given a diagnosis of the ICP. This is supported by the recent systemic review described above, in which there is no associations between the abnormal maternal transaminases concentrations and stillbirth. So, what terminologies they should be used to describe the conditions? Most published studies to date have including the women with the ICP diagnosed on the basis of the itch and elevated bile acids above the laboratory reference range. In a study of the 560 women, a pregnancy specific reference range for a non-fasting bile acids they was calculated with an upper limit of the normal of the 18 micromole per liter. In the light of the meta-analysis and the individual patient data analysis, they shows that the stillbirth risk is not linked with the alanine transaminases but in the link with the peak bile acid concentrations. The suggested terminology for the pregnant woman with the otherwise unexplained itching is outlined in the table 1. So this is the table 1, and these are the terminologies of the pregnant woman with the itching and the normal. So what is the gestation? Okay, one thing I want to explain here that every table in the guideline is very important. If you don't do the guideline properly, always do the tables properly. They are very important for the exam point of the view. So number 1 is the gestational pruritus, then the mild ICP, then moderate ICP, and then the severe ICP. The gestational pruritus will be defined when the itching and the peak bile acid concentration is less than 19 micromole per liter. Mild ICP itching and the raised peak bile acid concentration is 19 to 39 micromole per liter, and moderate ICP itching and the raised bile acid concentration 40 to 99 micromole per liter, and severe ICP itching and the raised peak bile acid concentration is more than or equal to 100 micromole per liter. Now, the next heading is what are the clinical issues for the women with the ICP. The clinical issues for the women and the pregnant people with the ICP may include the coping with the itching, monitoring operations during the pregnancy, options for the controlling the maternal symptoms, and the, reducing the fetal risk and the preterm birth, and difficulty sleeping and anxiety about the conditions and the optimal timing of the birth. Itching varies in the nature between the different women and for the some women at the different times, from the mild to unbearable, and from the focal to widespread, and for the some women that can have an adverse impact on their mental well-being. Liver failure, impaired synthetic function such as a prolonged prothrombin time, or the metabolic dysfunction such as hypoglycemia is not a typical feature. Now, the identification and assessment of the evidence. So this is not that important, you can leave it, because for the exam point of view, they are important but not that important. So moving to the next, how the ICP is diagnosed, how should the diagnosis of the ICP is made, and these are important, that the diagnosis of the ICP, they should be considered in the pregnant women who have itching in the skin of the normal appearance and raised peak random total bile acid concentration of 19 micromole per liter or more. The diagnosis is more likely if it is confirmed that the itching and the raised bile acid resolve after the birth. So the evidence quality is 4 and the strength is D. So the rationale for the recommendation, that there is no diagnostic test for the ICP, but this definition is pragmatic and is used in the clinical research involving the women with the ICP. So next, if a diagnosis of the ICP is suspected, carry out a structured history and examination so that the other causes of the itching and the liver dysfunctions, they can be excluded. There are other potential causes of the itching and abnormalities of the liver function test in the pregnant woman. Offer repeated liver function test and the bile acid measurement depending on the gestation and the clinical context in the women with the normal blood results which itch persist and no other cause is apparent. So the woman and the pregnant people with the gestational pruritus, they may develop the ICP up to 15 weeks after the initial presentation. If the resolutions of the itching is associated with the normalizations of the bile acid and the liver function test during pregnancy, the diagnosis of the ICP is unlikely to be correct. In clinical practice, the diagnosis, they should be considered or reconsidered if the clinical presentation changes. Now, or the new onset pruritus in the pregnant woman, if it is associated with rash, is unlikely to be ICP. Clinicians, they should be aware, however, that the skin condition, for example eczema and ICP, they can coexist. If the itchy skin looks normal or there is only the skin trauma due to the scratching, the diagnosis may include the gestational pruritus or the ICP. Measurement of the bile acid concentration and the liver function test, they should be undertaken. Raised bile acid concentrations of the 19 micromole per liter or more in the pregnancy, they support a diagnosis of the ICP. When clinically indicated, the bile acids measurements, they should be taken at the convenient time and do not need to be performed fasting, and by taking a known fasting upper limit of the normal up to the 19 micromole per liter for the bile acid concentration. Almost 20% of the women, they previously considered to have the ICP as their bile acid concentrations are below 19 micromole per liter but above the standard laboratory cutoff. Do not have the diagnosis. Published data indicates the pregnant woman with a raised bile acid less than 19 micron and not at increased risk of the stillbirth. In addition, prendial reading are the higher than the fasting. This approaches that maximizes the chances of the detecting the peak bile acid reading that are of the great clinical importance for the preventing the adverse pregnancy outcome. Itching of the normal skin, the liver dysfunctions and elevated bile acid concentrations are non-specific and have a wide range of the causes. A healthcare professional, they should carry out a structured history and examination and consider other potential diagnoses. These may be pregnancy specific, including the preeclampsia or coincidental to the pregnancy, comprehensively reviewed by the Walker et al. Drug reactions, allergic reactions, and the urticaria, they should form a part of the differential diagnosis. In the women and the pregnant people with the persistent age of the normal skin and the normal blood results and initial diagnosis of the gestational pruritus, they should be considered. Women, they can go on to develop the ICP up to the 15 weeks after diagnosis of the gestational pruritus. If the itching continues for these women, they should be offered review with the repeated liver function test and the bile acid measurement as clinically indicated. The frequency and durations of the review and the test, they should be determined on an individual basis, but high might be based around the scheduled care. The gestational age is also relevant in determining the test frequency, particularly later in the third trimester when the diagnosis of the ICPD may change care around the timing of the birth, aiming to reduce the risk of the stillbirth. Use the pregnancy-specific reference ranges for the liver function test. Pruritus and the biochemical abnormalities, they usually persist throughout the pregnancy in the women with the ICP, although it is very common for them to fluctuate. However, in a few women, the pruritus and the biochemical abnormalities, they will resolve completely for the remainder of the pregnancy. Clinicians, they may then need to consider the cause of the original symptoms and why the resolutions they have occurred. There are the many causes of the transient liver function test abnormalities, such as the drug reactions, for example, to the antibiotics, or the non-specific viral illnesses. When the resolution they occurs during the pregnancy, it is unlikely that the original diagnosis was correct. In the discussions with the woman or the pregnant person, the ongoing care, they can usually return to the normal, and decisions about timing of the birth, they should be based on the usual obstetric practice. Although there should be greater caution if the bile acid concentrations have been markedly raised, for example, 100 micromole per liter or more. So, what is the role of the other investigations in the care of the women with the suspected ICP? Additional laboratory and or the imaging investigations are not recommended in every woman, but could be considered on an individual basis. Consider antenatal testing only if there are the atypical clinical symptoms, presence of the relevant comorbidities, or the early onset of the severe ICP. Consider postnatal investigations in a woman in whom the resolution of the abnormal liver function test is delayed or do not occur. A cohort study, they shows that the likelihood that the routine investigations they would identify other causes of the clinical picture was extremely low. Previous RCG guidelines, they have recommended the routine laboratory and the imaging investigations to exclude other causes for the clinical picture of the ICP, including the viral and autoimmune disease test and the liver ultrasound. A recent retrospective review of over 500 pregnant women with the raised bile acid concentration, they suggest that the likelihood of the identifying a viral autoimmune or the structural cause for the itching and the liver derangement that was not suspected on the other clinical grounds is extremely low, or no new diagnoses were made following the investigations. Therefore, the routine use of the other investigations is no longer recommended. The UK National Screening Committee does not recommend the routine screening for the hepatitis C in the pregnancy due to lack of the evidence of the benefit. The same uncertain applies of the pregnant women with the ICP. Routine hepatitis C testing is therefore not currently recommended in a woman with the suspect or the proven ICP. Additional investigations, including for the hepatitis C, they should be considered in the woman and the pregnant people with an atypical or the uncertain picture of the ICP. This may include the women with a markedly elevated transaminases and early onset of the ICP in the first or the second trimester. A rapidly progressive biochemical picture and after features of the liver failure or the evidence of the acute infections, or if the resolution does not occur after the birth. These cohort studies of 223 women, 531 women, and the 745 women with the ICP who had the routine coagulation testing reported no case of the prolonged prothrombin time in the women with uncomplicated clinical presentations. The same number of the abnormal results were in the women with the alternative diagnosis. Coagulation testing is therefore not recommended routinely for the women and the pregnant people with the uncomplicated. It should be considered on an individual basis, especially when the failure of the liver synthetic functions of the failure of the fat absorption is suspected. So next, moving to the next, when should the specialist hepatologist advise to be sought? They consider discussing the care of the women with the severe very early or the atypical presentation of what appears to be ICP with the hepatologist. It is good practice to discuss complex or the unusual cases with the relevant specialist. Women who develop the pruritus and the abnormalities in the liver functions and the bile acids in the first or the second trimesters, and especially in the first trimester, are more likely to have an underlying genetic predisposition or an alternative additional diagnosis. Input for a hepatologist and a clinicians with a special interest in the cholestasis to discuss the investigations and treatment options they should be considered. A postnatal referral they should also be considered for the women and the pregnant people who do not have the resolutions of the age and the biochemical abnormalities after the birth. What are the usual postnatal resolutions? Confirm the diagnosis of ICP in the postnatal period at least 4 weeks after the birth with the resolution of the aging and liver function test returning to the normal, including the bile acids. It is good practice to ensure that the women with the ICP have the appropriate follow-up. For many women with ICP, itching will stop very soon after the birth. In the majority of it stops in the first few hours or the days, and liver function tests are not specific. They can become the abnormal during the birth. Alanine transaminase and aspartate transaminase are found in the smooth muscles, breast, and the red blood cells, and may be elevated for the other reasons in the immediate postpartum period. Women with the ICP who have no other diagnoses are usually clinically well, and liver function tests and the bile acids they should not be measured until at least 4 weeks after the birth to allow the time for the liver to return to the normal range. If the woman of the pregnant person is clinically unwell, other or the additional diagnosis they should be suspected, and the liver function test they should be repeated sooner as clinically indicated. What are the maternal morbidities? This is the heading of the maternal and the perinatal risk. Advise the woman with ICP that the predominant symptoms is the itching, and this can be severe and may fluctuate and may markedly affect the sleep. It is usual clinical practice to discuss the symptoms with the woman. And the woman with the ICP, they may have the higher chances of developing preeclampsia or the gestational diabetes. They should have the blood pressures and the urine monitoring and the testing for the gestational diabetes according to the national guidelines. It is important that the women with the ICP, they continue to have the normal aspects of the antenatal care. Itching is the main symptom of the ICP, and the itching is not specific to any single location, and if it is often generalized and may affect the palms of the hands and the soles of the feet. It vary in the intensity, and for women and the pregnant people with the gestational pruritus or the ICP, that is poor correlation between the severity of the itch and the level of the bile acids, and regardless of the diagnosis, itch can be very severe for the some women and may negatively impact their emotional well-being and the mental health. The itching is often more pronounced at the night, and which can interfere with the sleep. And additional symptoms of the cholestasis such as the dark urine and the pale stools are infrequently reported, and steatorrhea they may occur. And the women with these symptoms, they may have the malabsorptions of the vitamin K. Jaundice is rare and affecting less than 1% of the women with the ICP, and they tend to be mild if it occurs. The incidence of the preeclampsia was higher in the women with the ICP, and 12.2% of the women with the ICP they have the preeclampsia compared with the 3.4% of the women without the ICP. And as a preeclampsia, they can be diagnosed at any gestation from the mid-second trimester. Healthcare professionals, they should ensure that the woman and the pregnant people with the ICP receive the ongoing blood pressures and the urinalysis screening for the preeclampsia alongside review for the ICP. In a meta-analysis of more than 5,000 women with the ICP, rate of the gestational diabetes were higher in the women with the ICP, and 13.2% of the women with the ICP have already been diagnosed with the gestational diabetes, comparatively with the 5.9% of women without ICP and versus. Additional testing for the gestational diabetes is not currently recommended, and the risk assessment and Testing for the gestational diabetes, they should follow the national guidelines. A large Swedish population-based study of the 11,388 women with the ICP and 13,893 controls found that the women who have had the ICP had an increased likelihood of the later being diagnosed with the hepatobiliary disease and hazards ratio HR 2.62, which is 95% of the CI 2.47 to 2.77. 15% of women with the ICP, they versus 6.3% in the controls, predominantly due to the gallstone diseases, and 11.6% versus 1.6%. However, the gallstones are common, affecting 5 to 25% of the adults in a higher income countries, and it is unclear whether the gallstones disease predates ICP in such women. The same studies, they found an associations between the ICP and the immune-mediated disease later in the life, and these includes the diabetes and thyroid diseases and psoriasis and inflammatory polyarthropathies and the Crohn's disease, but not ulcerative colitis. And the most of these conditions remains at the low absolute incidence, and the benefit of the routine regular screening for these conditions is not proven in the women and the pregnant people after the ICP, and is not currently recommended. Women with the ICP, they have reported the small increased chances of the subsequent diagnosis of the other conditions such as the hepatitis C. The UK strategy for the hepatitis C detection is based on additional investigations on the high risk groups and does not at present include the women with the current or the previous ICP. In general, after an episode of the ICP, women do not require the additional screening and nor the follow-up. So, what are the risks of the stillbirth? Advise the women with the isolated ICP and a singleton pregnancy that the risk of the stillbirth only increases above the population rate once their serum bile acid concentration is 100 micromole per liter or more. In the women with the peak bile acid 19 to 39 micromole and no other risk factors that advise them that the risk of the stillbirth is similar to the background risk. And in the women with the peak bile acid 40 to 99 micromole per liter and no other risk factors advise them that the risk of the stillbirth is similar to the background results until 38 to 39 weeks gestation. And in the women with the peak bile acids 100 micromole per liter or the more advise them that the risk of the stillbirth is higher than the background risk. The demonstrated in the meta-analysis of the 23 studies and advise the women with the ICP that the presence of the risk factors or the comorbidities such as the gestational diabetes or the preeclampsia and the multi-fetal pregnancies and appears to the increased risk of the stillbirth and may influence the decision making around the timing of the planned birth. Advise the woman with the ICP and a twin pregnancy that the risk of the stillbirth is higher compared with a twin pregnancy without ICP. The stillbirth remains a major concern for the women and the pregnant people with the ICP and for their healthcare practitioners. A large systemic review and the individual patients data meta-analysis of the women with the ICP reported that for the singleton pregnancies, the risk of the stillbirth only increased above the population and rate once the serum bile acid concentrations were 100 micromole per liter or more. The national stillbirth rates for the 28-week gestation for the 2015 for the country contributing to their ICP data varies from the 0.18% to 0.72 depending on the country. The UK stillbirth rate was 0.29%. The pathophysiology of the stillbirth in the ICP is uncertain, but it is thought that the bile acids may cause an acute fetal anoxic event and possibly due to the fetal arrhythmia or acute placental vasospasm. In singleton pregnancy, stillbirth was associated with a peak total bile acid concentration but not with the alanine transaminases. A 12-month UK obstetric surveillance system study in 2010 to 11 reviewed 669 cases of the one ICP in the singleton pregnancy with the bile acid 40 micromole per liter or more across the UK, which includes the 10 stillbirths. Of these, 7 had coexistent pregnancy complications. The 3 had the gestational diabetes, 2 had the preeclampsia, and 2 had non-specified complications. These differences they remained significant against the national data and study that the women with the ICP and the other comorbidities they warrant the additional surveillance. The etiology of the adverse perinatal outcomes, including the stillbirth in the multifetal pregnancies, is the multifactorial. The risk of the stillbirth is the multifetal pregnancy is higher than that in the singleton pregnancies. Once a retrospective cohort study from the China specifically evaluated ICP in the twin pregnancies. They reviewed 129 twin pregnancies complicated with the ICP and 1793 twin pregnancies without the ICP. There was an increased risk of the stillbirth in the twin pregnancies with the ICP compared with the twin pregnancies without the ICP. This was the further stratified as the stillbirth risk of the 3.3% in the women with the bile acids of 10 to 39 micromole per liter and the 5.1% in the women with the bile acids of the 40 micromole or the more. Stillbirth with the ICP in the twin pregnancies they occurred between the 33 to 35 week gestation compared to 36 to 38 week gestation among the singleton pregnancies. So here was a paragraph which is the associations between the peak bile acid concentration and the prevalence of the stillbirth in the singleton pregnancy. So the national UK stillbirth rate from the 28 weeks, peak bile acid concentration and prevalence of the stillbirth with the 95% of contraindicated absolute number of the stillbirth and the hazards ratio. So there is less data that the national UK stillbirth rate from the 28 weeks is the 0.29% and mild ICP. It has raised bile acids from 90 to 39 micromole per liter and the prevalence of stillbirth is 0.13 and the absolute numbers of the stillbirth are 2 by 2310 and the hazards ratio is the reference. Then the moderate ICP when the bile acid level was a 40 to 99 micromole per liter, it is the 0.28%, and the severe ICP more than 100 it has 3.44% of the stillbirth chances. So what are the risks of the perinatal morbidity? The advice women with the moderate or the severe ICP that they have a high chances of the both the spontaneous and the iatrogenic preterm birth. And recommendation: advise the women with the moderate or the severe ICP that they have the increased chances of having the meconium stained amniotic fluid during the labor and the birth, and advise the women with the moderate or the severe ICP that their baby is more likely to receive the neonatal care. And now moving next, that in the meta-analysis of the about more than 5,000 women with the ICP, the women with the bile acids more than 40 micromole per liter, they had an increased overall risk of the both the spontaneous preterm birth and the iatrogenic preterm birth, and the later likely reflects a policy of the active management with the planned early birth. And the percentage of the women with a singleton pregnancy who gave the birth before the 37 weeks increases with the increased bile acid concentration of the women with the bile acid below the 40 micromole per liter, of the women with the bile acid 40 to 99 micromole, and of the women with the bile acid 100 micromole per liter or more. And the majority of the multi-fetal pregnancies they were born preterm. In the same meta-analysis of more than 5,000 women with the ICP, there was an increased chances of the meconium stained amniotic fluid in the women with the ICP. The 2010-2011 GTG study of the 713 women with the bile acid of the 40 micromole or more found that these women they had the meconium stained amniotic fluid at the lower gestational ages and more commonly at the 35 to 38 weeks with compared with the women with the ICP. The presence of the meconium stained amniotic fluid in the labor they should be managed using the national guidelines. ICP is associated with the small increase in the admissions to the neonatal units, and there was however no difference in the rate of the neonatal 5-minute APGAR score of less than 7, and which is associated with an increased neonatal morbidity and mortality. And the 2010-11 GTG study of the 713 women with the ICP, they showed that 45% of the neonatal admissions they were due to the preterm birth and 30% are due to the respiratory problems. And their study had the preterm birth rate of the 25% with a 15% rate of the meconium stained leather, but no cases of the meconium aspiration. The median duration of the stay in the neonatal is unit was the 7 days. So, how should women with the ICP be monitored? Review women with the ICP within a consultant and maternity unit. The frequency and the content of the monitoring for the women and the pregnant people with the ICP, they should be determined in the conjunctions with the women or the pregnant person and based on the amount of the discomfort or the distress they experience. Bile acid concentration, gestational age, and the presence of the other morbidities. This might incorporate review of the diagnosis, discussions of the maternal and the fetal well-being, treatment of the pruritus, and need for the further biochemical testing. And what maternal monitoring they should be advised that for the women with the ICP, consider repeating the liver function test and the bile acid after 1 week and then determine the frequency on an individual basis. And maternal age appears to be poorly correlated to the level of the biochemical abnormality. And for women with the ICP, ongoing monitoring of the symptoms and the biochemical monitoring, they may show the rise bile acid concentrations of if 100 micromole or the more, and the diagnosis of the severe ICP. The fall in the bile acid concentration into a more reassuring category, such that the frequency of the monitoring and or the care and they can be altered accordingly. The spontaneous resolutions of the itch and the biochemical abnormalities, they returning to the normal levels, in which the case that is diagnosis, they should be considered fluctuating bile acid concentration, but the peak concentrations within the boundaries of their current diagnosis. All women with the itch and an initial raised bile acid levels, they should have a second bile acid measuring repeated around the 1 week after, later before any diagnosis or care decisions they are determined. Or it is common for the women with the bile acid levels over the 100 micromole per liter and 40 to 100 micromole per liter to have the subsequent bile acid concentration that are much lower. The subsequent frequency in which the women and the pregnant women, they have the biochemical assessment with the determined or an individual basis, and according to the impact that the results they might have on the future cases. If the woman with has a mild ICP with the peak bile acids 13 to 19 to 39 micromole per liter, they could have the weekly testing they approach 38 weeks, and in order to inform the timing of the birth. If the woman they has a moderate ICP with the peak bile acid 40 to 99 micromole, especially if they are approaching 35 weeks gestation, weekly testing they should be considered as the timing of the birth. They may be influenced if the level raises to 100 micromole per liter or more. If the woman with if the woman that has a severe ICP with the peak bile acid concentration of 100 micromole per liter or the more, the further routine testing of the bile acid, they might not impact on the decision making and therefore may not be routinely required. What's the fetal monitoring they should be advised? Clinician, they should be aware that the fetal ultrasound or the cardiotocography, they do not predict or prevent the stillbirth in the ICP, and advise the women with the ICP to monitor the fetal movements and presence for the immediate assessment at their local maternity unit if they have any concern. In ICP, there is evidence that the cardiotocography, the monitoring or the biophysical profile, they do not predict the stillbirth, and the several studies they describe the fetal death despite the close surveillance and previously the normal ultrasound scans and biophysical profile or the CTG monitoring. ICP is not associated with the fetal growth restrictions, with no difference in the birth weight centiles and compared with the babies born to the women without the ICP, and therefore strategies for an antenatal monitoring for the placental insufficiency are unlikely to be beneficial in the women with the isolated ICP. All the pregnant women and the pregnant people, they should be advised to monitor the quality and the quantity of their fetal movements and report any reductions or the changes to their local maternity unit immediately, as recommended in the national guidance. And the maternal detections of the movements is simple and not time consuming for the women or the staff, but its specific role in the monitoring the pregnancies communicated by the ICP has not been assessed. What is the role of the drug treatment in the treatment of the ICP? What impact on the maternal symptoms, age, maternal biochemistry, and the fetal outcome they can be expected? Advice women that there are no treatment that improve the pregnancy outcome or the raised bile acids concentrations, and treatment to the improve the maternal itching care of the limited benefits. The role of the drug treatment in the ICT is to try to reduce the maternal itching, which may be of the variable intensity and is unrelated to the bile acid concentration, and there is no evidence that the routine medical treatment they improves the maternal raised bile acid concentrations or the perinatal outcome. Then the considered topical emollients such as the aqueous cream with or without the menthol added to the ameliorate the skin symptoms. And all there, though there is a minimal high quality evidence to the endorsed topical emollients treatment in the women with the ICP, and it is not a disease modifying drug, and there is consequences that the such treatment they may relieve some of the discomfort and associated with the itching and has no known harmful effects. Then the antihistamines. Consider antihistamine agents such as the chloramphenemine, and particularly at the night, although the effectiveness of this treatment is uncertain in women with the ICP. And the chloramphenemine, they has the antihistamine properties and may have the sedative side effects in the some women. The effectiveness of this treatment is uncertain in the women and the pregnant people with the ICP, and relief may be more related to its sedative actions that is a direct effect. There is experience of using the chloramphenemine in other countries. There is evidence of using chloroquine in the other conditions in the pregnancy, such as the hay fever, and the harmful effects they have not been reported. Other common antihistamine agents, including the loratadine and the cetirizine, they are also used in the pregnancy for the other indications, but do not have the sedative side effects. And the ursodeoxycholic acid, it is do not recommend after the offer the ursodeoxycholic acid for the purpose of the reducing the adverse perinatal outcome in the woman with the ICP. The evidence from the randomized control trials, they shows that there is no reductions in the adverse perinatal outcome in the women prescribed the ursodeoxycholic acids compared to the women in the placebo group, and the no subgroup, for example, based on the maternal bile acid concentrations or the gestational age at the presentations, was identified that might benefit. There is a small around 5 mm or the linear 0 to 100 mm age scale with the 0 no age and 100 worst imaginable age. The reduction in the maternal age in the women they taking the ursodeoxycholic acid. Women and the clinician they consider that the reductions of the at least 30 mm on the age scale they would be clinically relevant and worthwhile. The majority of the women they would therefore not consider these are useful treatment. It remains possible that the some women and the pregnant people the itching they may reduce with the ursodeoxycholic acid, but it is not clear how such the women they might be identified. A recent secondary analysis of the large trial they could not identify a cohort basis on the bile acid concentrations or the H score who would benefit. A systemic review and the individual participant meta-analysis of the ursodeoxycholic acid in the ICP, they included 4 randomized control trials of the over 800 women, of whom 183 had the bile acid of 40 micromole per liter, and with a primary outcome of the stillbirth and composite secondary outcome of the stillbirth and the preterm birth. Ursodeoxycholic acid they had no impact on the primary endpoint, and spontaneous preterm birth under the 34 weeks gestation was not reduced. Women taking ursodeoxycholic acid versus 6 by 366 women taking the placebo. Spontaneous preterm birth under 37 weeks of the gestation was reduced in the women taking the ursodeoxycholic acid compared with the placebo. In the women with the bile acid concentration 40 micromole per liter or the more, who are 34 to 36 weeks gestation are ursodeoxycholic acid. They may offer some benefits in reducing the later preterm birth. However, as with the other circumstances where the preterm birth they occurs, it is not clear that this reduction the results in any benefit of the baby or to the baby. The optimum strategy, the gestation and the dosing the regime are the unclear. Some women and pregnant women with the bile acid concentration of 40 micromole per liter or the more or may wish to take the ursodeoxycholic acid with a view of, or to the prolonging the gestation, but as this does not prevent the stillbirth, the advantage of the doing also may be less clear, especially for those with the bile acid over the 100 micromole per liter. In the largest trial, the maternal bile acid concentrations they were found to be higher in the group treated with the ursodeoxycholic acid, possibly as a result of the standard laboratory assay being unable to distinguish between the endogenous and exogenous resources. Ursodeoxycholic acid they cannot therefore be recommended for the purpose of the reducing this biochemical maker of the disease. In the same trial, the women they treated with ursodeoxycholic acid have had the lower alanine transaminases and levels that these taking the placebo, but the clinical implication of this are the uncertain. And the alanine transaminases, other agents do not offer other agents for the treatment of the ICP outside of a research study or the individualized specialist treatment. And the use of the rifampicin has been reported largely in a single cases and by a questionable survey of the affected women, but there is no evidence from the randomized control trials to support its routine during use in the ICP. Further, the researchers is underway to evaluate its use in the women with the ICP, in women and the pregnant people with the early onset serious severe diseases, and opinion from the specialist in ICP they should be sought before considering the rifampicin treatment. Is there a place for the vitamin K use? So the considered maternal vitamin K treatment only if there is appears to be reduced absorptions of the dietary fats, for example the presence of the steatoria or the evidence of the abnormal prothrombin time if the coagulation studies are performed. And the experience of the experts is that the large majority of the women with the ICP will not have the evidence of the reduced fat absorptions, and the routine use of the vitamin K treatment is not indicated. If the women they have the symptoms such as the steatoria, the coagulation assessment they should be performed and use of the vitamin K treatment considered. And how does the woman be advised on the timing and the mode of the birth? They consider the options of the planned birth by the 40 weeks gestation or the ongoing antenatal care according to the national guidance in the woman with the mild ICP, bile acid 19 to 39 micromole per liter, and no other risk factors advise the woman that the risk of the stillbirth is similar to that of the background risk. And consider the planned birth or the 38 to 39 week gestation in the woman with the moderate ICP with the peak bile acids 40 to 99 micromole per liter, and there is no other risk factors advised that the overall risk of the stillbirth is similar to the background risk until the 38 to 39 weeks. Consider the planned birth or at 35 to 36 weeks gestation in a women with the severe ICP with the peak bile acids 100 micromole per liter or more. Advise them that the risk of the stillbirth is higher than the background risk, and advise the woman that the presence of the comorbidities such as the gestational diabetes, preeclampsia, multifocal pregnancies appear to increase the risk of the stillbirth and may influence the decision making around the timing of the planned birth. So active care in the ICP, they usually the referring to the planned birth around the 38 week gestation came into the practice in many settings including the UK, and despite the inadequate evaluation of its benefits or the understanding of which the women with the ICP they might be increased risk of the adverse perinatal outcomes, and the previous studies they had reported or the cohort of the women with the ICP often after introductions of the active care and speculated the low stillbirth rate risk is related to such a policy, but the fewer had evaluated the prognostic factors to allow the better stratification to the tailored timings of the birth. A large systemic review and individual patient data meta-analysis of the women with the ICP, they has reported that the risk of the stillbirth of is 0.13% in the woman with the peak bile acid less than the 40 micromole per liter, which is not higher than the background population risk. And although the risk of the stillbirth remains low throughout the gestation for these women, the benefits of the counting the pregnancy after the 40-week gestation and may be outweighed by the risk. Therefore, it is reasonable to discuss with the woman or the pregnant person whether they wish to continue the pregnancy or have the planned pregnancy. The risk of the stillbirth woman with the peak bile acid of the 40 to 99 micromole was 0.28%, and this was not higher than the other all background population risk, and but did appear to increase at around 39 weeks gestation. Although the number of the affected pregnancies is small and the confidence interval wide, and it is reasonable to offer the planned birth at the gestation age, gestation for the women and the pregnant people with the peak bile acids of the 40 to 99 micromole per liter or the earlier if the other comorbidity gestation, diabetes or the preeclampsia are the present. For the women with the peak bile acids of the 100 micromole per liter or the more, the risk of the stillbirth is the 3.44%, which is higher than the background population rate, and the risk appears to be increased for the 35 to 36 weeks gestation. This information they should be shared with the woman or the pregnant person, and the planned birth considered based on the factors and the woman the preference. This is in the keeping in with other studies including the different methodologies and including a retrospective cohort study of the 1604386 pregnancies and assessing the composite perinatal morbidity mortality risk, and the decision modeling the study concluding that the 36 week gestation was the optimal. And in the woman with the ICP and the peak bile acid 40 micromole or the comorbidities, they may be considered associated with the greater risk of the stillbirth, and the presence of the any risk related to the comorbidities they should be taken into the account when the considering the time of the planned birth. So, the mode of the birth advice women that the ICP in itself they does not impact their choice around the mode of the birth, and that their decision they should be based on the usual obstetric practice for the women. The women and the pregnant people with the ICP they do not have the increased rate of the assisted or the operative birth compared with the women without ICP. Mode of the birth should therefore be based on the usual obstetric or the medical indication. If the planned early birth is indicated, inductions of the labor they should be ensured or considered unless other it is considered unless the other reasons for the cesarean birth are the present. And monitoring in the labor. Offer the continuous electric fetal monitoring to the women with the peak bile acids 100 micromole per liter or more, and there is insufficient evidence for or against continuous electrofetal monitoring in the woman with the peak bile acid below 100 micromole per liter. Shared decisions on the can be made based on the comorbidities and the preference. Advise the woman that the presence of the risk factors such as the gestational diabetes, preeclampsia, and the multifetal pregnancies and appears to increase the risk of the adverse perinatal outcome, and that their conditions themselves they may necessitate the monitoring during the birth or in the conjunctions with the ICP may influence the decision making around monitoring in the labor. Advise the woman that the meconium strain liker is more common in the moderate and the severe ICP, and that this will influence the decision making around the CFM. If the woman or the pregnant person they has the existing obstetric or the medical conditions that influence the decision making around the fetal monitoring in the labor, they should be taken into the account when they're planning the intrapartum care. In the women with the mild ICP and no other risk factors, the intrapartum care they can follow the national guidelines. And the women with the moderate ICP, the decision making they should be made on the individualized basis, and explaining that the benefit of the continuous electronic fetal monitoring is uncertain. The presence of any other risk factors they should be taken into account. In the women with the severe ICP, in the light of the evidence that there is a risk of the adverse perinatal outcome in the women, continuous electrofetal monitoring they should be offered. And women and the moderate and the severe ICP they may are more likely to have the meconium stranding likers, and this will influence the need for the continuous electro monitoring in the labor. and what is the analgesia in the labor, and offer the women with the uncomplicated ICP the standard analgesia and anesthesia options for the birth. And there is no studies that they have the evidence that the women on the pregnant people with ICP they requires different options for an analgesia or an anesthesia for the birth, and the national guidance they should be followed. And three cohort studies of the 223 women, 531 women, 745 women with ICP described above the session who have the routine coagulation testing report and no cases of the prolonged prothrombin time in the women with the uncomplicated clinical presentations. And this the small number of the abnormal results occurs in the women with the alternative diagnosis. So third stage of the labor, and advise the woman that there is no evidence of an increased risk of the postpartum hemorrhage if they have the uncomplicated ICP, and a case and the cohort they stages they birth showed and no increased risk of the postpartum hemorrhage in the woman with ICP. Standard care using the national guidance for the third stage of the management they should be followed. What follow-up they should be offered to a woman who have had the pregnancy affected by the ICP, and for the women who have the uncomplicated ICP follow-up they should arrange at least 4 weeks after the birth to confirm the resolution of the ICP, and advise them that they should be anti-state itching and the raised maternal bile acid concentration and to resolve the after the birth. And in the women who have had the ICP, they usually stop after the birth and often in the first few days, and liver function test and the bile acid concentrations they should return to the normal within the few weeks. And after at postnatal follow-up, the healthcare professionals they should ensure that the itching has resolved, and they should confirm that the maternal bile acid concentration and the liver function test they have the normalized with the itching or the biochemical abnormalities that persist beyond the 6-week postpartum considered the diagnosis depending upon the history and examinations finding, and referral to the hepatologist they may be required. So what advice they should be offered to for the future contraceptive or the hormonal options? Advise the women that ICP itself does not influence their choice of the contraceptive hormones or the replacement therapy. For women with ICP and the previous cholestasis secondary to the combined hormonal estrogen containing the contraception, advise them to use the progesterone only or the non-hormonal methods. In women with previous ICP requesting the HR, they consider offering it if there is no other contraindication to use. As with all the women and the pregnant people, the discussions about the method of the contraception should be begin during the antenatal period and continue the early postpartum care. And this they should include the health benefits of the spacing the pregnancies and consideration of the medical conditions or the patient characteristics affecting the contraceptive choice, such as the venous thromboembolism risk factors, the breastfeeding, the medical history, the reliability and the benefits of the long-acting reversible contraceptive methods, and the additional use of the condoms if there is a risk of the sexually transmitted disease and HIV. The 2016 UK medical eligibility criteria UKMAC for the contraceptive use, they advise the copper bearing intrauterine devices and liver non-gestational releasing intrauterine systems, progesterone implants and progesterone injectables and the progesterone only pills. They can be used without restrictions in the woman with the history of the ICP. And combined hormonal contraceptives they can be used in the women with ICP, and provided that there is they do not also have the history of the contraceptive related cholestasis. It was previously thought that the women with the history of the ICP they may have the increased risk of the developing the cholestasis with the using the estrogen containing hormonal contraceptive, but this is unlikely for the majority of the women. The 2016 UK MAC states that in women who have had the ICP that the advantage of using the estrogen containing methods outweigh that this theory's theoretical risk, and the women they may thus choose to use this method, and the resolutions of the itching and the liver function test and the bile acid concentration returning to the normal levels they should be confirmed before the commencing this method, and advise the women to attend for the review of the reference of the itch and the abnormal liver function test occurs while using the combined hormonal contraceptions, and this would give a diagnosis of the contraceptive related cholestasis, and alternative contraceptive options they should be discussed. For the women with the atypical presentation of the ICP, atypical postnatal clinical course, while where other diagnoses are the suspected, and or where the itching and the liver function tests they have not resolved, a personalized approach to the contraceptive choice they should be undertaken with the provisions of the information about the avoidance of the pregnancy with the active liver disease. For menopausal women, the considering the hormonal replacement therapy, the national recommendations they should be followed, and the current UKMAC guidance is that the estrogen containing the contraceptive can be used in a woman with the history of the ICP if it therefore seems reasonable to offer the low physiological dose of the estrogen found in the HRT with the review of the use in the woman developing the itching or the other signs of the cholestasis. How should the woman be cared for in the future pregnancies? Advise women with a history of the ICP that they have an increased chances of the recurrence of the ICP and the subsequent pregnancy. Perform a baseline liver function test and the bilateral consultation with the booking blood investigation. So the women and the people of the at the reproductive age who have had their pregnancies complicated by the ICP, they have an increased chances of the ICP in the subsequent pregnancies compared to the general pregnancy and their population, but the precise magnitude of this is unclear as quoted rated of the current are the based on the small studies, and the results they may be generalized to the wider UK population with ICP at booking in the subsequent pregnancies. Baseline measurement of the liver function test and the bile acid concentration they should be performed in order to establish that they are the normal. They should only be repeated if the clinically indicated. So what is the recommendation of the for the future research? We don't need to do this at this time when we are preparing for the exam. Then the on-table topics no need, and useful links here give us some useful links, and also they are given the some references. So here conclude this our first session or the first RCG guideline, and hope you like the video. Stay tuned and stay blessed. Bye bye.